how do you decide on the number of bars that will be used for each person? And then can you also talk about how the number of bars could affect bar displacement?
How many bars? When Nuss first started doing this procedure and presented this procedure, it was on very, very young kids, not even teenagers, young kids. And they did one bar right in the center of the defect. And as the procedure carried on, and they started putting it into teens and now older patients, initially people didn't change that. They were still trying to do one bar. And there's good studies now that show that if you do one bar in the center of the defect, it's a ton of pressure versus if you do two bars. Nobody's done a study on three, but they've looked at one and two. And so if you look at the risk of a bar moving, having chronic pain, it's going to be a lot greater if you have only a single bar. Now, why would you go to three bars? Well, if you look at myself or you look at Dr. Park and the guys at Cleveland and many other surgeons, we're doing more and more three-bar procedures. Not everybody needs three bars, but you want to lift the entire chest, balance the entire defect. And so if you have somebody that has a really long defect, you need three bars to lift that out. If you have someone that's got a small defect down here, you could get by with two bars. And sometimes we even cross the bars to give more outward push. But you have to fix the defect. And if you don't fix the defect completely and you lift up here and you leave it caved in here, there's a chance that you may still have cardiac compression, which is, the patient's still going to have symptoms. And that's the primary reason we do this procedure, is to help patients with their symptoms.